Greetings and a warm welcome to everyone. I am Asia, the assigned moderator from DentalNet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. DentalNet is a dedicated all in one medical content platform designed exclusively for dental professionals. Our mission is to empower dentists, hygienists, dental specialists, and students with cutting edge evidence based knowledge to elevate patient care and foster ongoing professional growth. At DentalNet, we bring together a nationwide network of dental experts to share their knowledge, clinical experience, and practical wisdom. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Pankaj Agarwal, sir, who is an oral pathologist, microbiologist, and oral implantologist, and is a distinguished clinician and academician with extensive expertise in oral pathology, microbiology, and implant dentistry. He holds the esteemed qualifications of BDS, MDS, and FAGE and currently serves as professor in the Department of Oral Pathology and Microbiology. Through his academic and clinical experience, he has made significant contributions to teaching, research, and evidence based dental practice. Based in Agra, Dr. Agarwal is widely respected for his dedication to advancing oral healthcare and mentoring the next generation of dental professionals, and we are extremely delighted to have him with us today. The topic for today's session is oral biopsy, how to avoid common diagnostic errors. This webinar is in association with POPMA, that is Practicing Oral Pathologist and Microbiologist Association, which is a national professional organization dedicated to promoting and advancing the specialty of oral pathology, oral microbiology, and diagnostic sciences in India. The association actively works to strengthen and expand oral pathology practice by enhancing professional recognition, creating academic and diagnostic opportunities, supporting policy advocacy, and fostering collaboration among oral pathologists, clinicians, researchers, academicians, and laboratory professionals. Through continuing educational programs, study clubs, research initiatives, public awareness campaigns, and professional networking platforms, POPMA strives to highlight the critical role of oral pathologists in disease diagnosis, oral cancer detection, laboratory medicine, and patient care. Under the leadership of Dr. Bhuvan Nagpal, POPMA is committed to building a stronger future for the specialty while promoting excellence, innovation, and evidence based practice in oral and maxillofacial pathology. So, without any further delay, I would now like to hand over this session to Dr. Pankaj Agarwal, sir, to share his insights. You may proceed with your talk, sir. Over to you.
Thank you very much, ma'am, for giving such a nice introduction for mine. And first of all, I would like to thank Dr. Bhuvan Nagpal, sir, and Dental Net for giving me this opportunity to share my knowledge among all my colleagues. So, the today's topic, which I've been given to discuss with you all, is oral biopsy, how to avoid common diagnostic errors. So, first of all, as we all are oral pathologists, most of us who are listening to me, and we all know what actually is biopsy. Biopsy, let me tell you, it's just a small tissue which is taken from the oral cavity and it has to be seen under microscope to determine the exact nature of the lesion and extent of the lesion. So most of the time, biopsies are done by oral surgeons, but we promote that general dentist should also be aware how exactly that person should go for biopsy. First of all, let us discuss why exactly biopsy is very, very important. So many other investigations are being done, like radiographic investigations, clinical investigations. But at the end, the topic comes biopsy. You have to do biopsy because it's a gold standard for the diagnosis of any oral lesions, or we can say any head and neck lesion. It differentiates between a benign, pre-malignant, and malignant lesions. And it also, the type of biopsy helps to determine the treatment planning. It helps the oral surgeon how exactly he should move forward for his surgery. Biopsy also determines, depending upon the grade, what exactly is the prognosis for the disease. And it also prevents unnecessary larger surgical enucleation or surgical removal of any part of the oral cavity. So that's why biopsy is very important for the exact treatment planning. So as the name of my topic today is, there are so many diagnostic errors which can occur, which can lead to failure of oral biopsy. Most of the time, biopsies are getting failed in pre-analytical clinical steps before the biopsy is being done. Very few cases can fail because of misinterpretation by a oral pathologist. This means if a proper technique is not being followed, proper procedure is not being followed, that can lead to non-diagnostic reports. That can also lead to false negative, means the lesion is there, but biopsy report is showing that there is no malignancy or there is no disease. At that time, as a pathologist, we suggest, okay, surgeon, you please repeat the surgical procedures. Sometimes this all, that is the failure of biopsies and the wrong technique of taking biopsies, can lead to certain medical legal issues also. Most of the time, if we enumerate the reasons behind the failure of biopsies, it can occur because of inadequate clinical examination of the patient, directly jumping into taking of biopsy. Then the second might be we are choosing a wrong biopsy site. We are not going towards the exact lesional site. Okay, once the tissue is being taken, if the proper handling of the tissue is not being done, that again can lead to diagnostic errors in oral biopsy. Again, the tissue is being taken, then it has not been properly handled, or it has not been properly fixed, or it has not been properly transported to the oral pathologist, can lead to diagnostic error. Okay, again, the insufficient clinical history of the patient is being sent to the oral pathologist by the surgeon, can lead to certain errors in oral biopsy report. And finally, the slide is ready and it is being examined by oral pathologist under the microscope, and there might be certain errors during the interpretation of the oral biopsy. So before the procedure of biopsy is being done, that is the surgical removal of the tissue, before that procedure is done, there can be certain reasons which can lead to diagnostic error, and the most common under that is the incomplete clinical examination of the patient. The surgeon is not completely examining the oral cavity, what exactly and where exactly is the lesion. Is there any smaller lesions also along with the larger lesions? Whether he has to go to check for the cervical lymph nodes which are present, and he has not documented the lesion, he has not taken the proper extent of the lesion, the size, the depth, he has not taken photographs. So the incomplete clinical examination of the lesion can lead to biopsy errors. All this can be avoided by the pre-surgical complete oral examination of the patient. There should be proper measurement of the lesion. There has to be proper photography of the lesion so that a documentation can be done. We have to ask the patient regarding the time duration since the lesion is present. What are the different symptoms? What are the different habits he is having, so that it can be sent to the oral pathologist, which will help in diagnosis of the lesion. Second thing, the clinician is giving a wrong clinical diagnosis. Like, the clinician is not doing biopsy for a lesion which is standing more than 14 days. That has to be done. For a lesion like leukoplakia, erythroplakia, unsupported or unreasonable swelling of the tissue, any vesicular lesion, or any mixed white and red lesion, they are not taking biopsy for that. Sometimes leukoplakia is like been given by clinicians as clinical diagnosis for frictional keratosis, lichen planus, or chronic candidiasis. Sometimes there are ulcers which they have thinking for trauma, squamous cell carcinoma, or tuberculosis. Always a clinician has to give a differential diagnosis. He has to think according to the clinical aspect and gives the differential diagnosis what it can be. Because at the last, when he is sending the tissue to the pathologist, he will see the microscopic histopathological aspect of the lesion and will let us know what exactly is the disease. And the next most common diagnostic error which can occur before the biopsy is being taken is the selection of site from where the biopsy is taken. Mostly the biopsy has to be taken from the most representative side of the lesion. It has to be taken along with the lesional tissue and also along with the non-lesional tissue. It has to have proper depth. It has to have both epithelial and connective tissue interface so that a proper diagnosis can be made. A biopsy should always be avoided from any necrotic tissue which is present. From the base of the ulcer, we should avoid, and we should also avoid biopsy from any inflamed tissue or any hyperkeratotic surface. All these areas should be avoided. Biopsy has to be taken from a junction of the normal and abnormal tissue. In this diagram, as you can see, if the biopsy is being taken from the lesional only, so that is not of value because we cannot compare the normal tissue with the lesional tissue. The other diagram which you can see, that is the most approximate or the appropriate area from where the tissue has to be taken. Selecting the best area for the biopsy. From the clinical knowledge, you should try to take the biopsy from the most suspicious area. Take area or take biopsy from red areas, any indurated areas, nodular areas, or non-healing ulcer margin. Just avoid any taking biopsy from white keratinized area only. After all the clinical pre-biopsy errors, now the second category under which we can discuss the most common diagnostic errors during the biopsy procedure errors when the clinician is performing the biopsy. Because as we know, there can be different types of biopsy. It can be incisional biopsy, excisional biopsy, punch, or it can be FNAC, fine needle aspiration cytology. Actually, all the biopsies, the type of biopsy which has to be performed, there are certain criteria which has to be properly followed before we have to finalize or we have to conclude that we are going for incisional or we are going for excisional. If the lesion which we see in the oral cavity is less than 1 centimeter and it is not looking much more suspicious, then directly we can go for excisional, that is the total removal of the lesion, and send it to the oral pathologist. If the lesion is larger than 1 centimeter and it is a larger area, then it definitely has to go for a small part of the tissue has to be removed. That is, it has to go for incisional type of biopsy. If it is looking like a suspicious tissue, that is looking like a ulceroproliferative type, at that time we should not go for excisional. It always has to be go for incisional biopsy. Any unreasonable swelling or any vesiculobullous lesion is there, vesicles or bulla are present, at that time we have to take biopsy from the perilesional area, not from the vesicle or bulla itself. Okay, after the area has been decided or the type of biopsy has to go, then the next thing comes how much tissue we have to take so that a proper diagnosis can be made by the oral pathologist. So that sometimes to be on a safer side or to be more conservative, we take a very small specimen. So the small specimen can cause sampling error. That tissue might not be sufficient for the histopathological diagnosis. In that tissue, we can miss certain dysplastic features and it can lead to again inadequate diagnosis of a lesion. So ideal specimen which we should take for the biopsy, it has to be 1 to 1.5 centimeter in length. Depth, it should include the connective tissue area. Along with the epithelium, it has to involve the connective tissue so that a proper amount of tissue is there and we can go for the further processing of the tissue and the final histopathological diagnosis. Always a proper depth of the biopsy has to be done. If we take a superficial biopsy, that is the superficial tissue is being taken, only the epithelial part, then we will not be able to compare where exactly the dysplasia is limited to the epithelium or it has crossed the basement membrane and it's undergone the basement underlying connective tissue. So a special particular thickness of the biopsy has to be there. Otherwise, it will be difficult for the oral pathologist for the diagnosis of the invasion area of the lesion. Okay, after the tissue is being taken, depth is being determined, length of the tissue is being determined. The next thing comes when we are handling the tissue. Okay, we are using certain forceps. If you hold the tissue very hard, again, that will lead to crushing of the tissue. This will cause forceps artifact. That will lead to changes in the architectural pattern of the cells and the nucleus. There will be cellular destruction. There will be nuclear distortion. So it has to be avoided. It can be avoided by gentle handling of the tissue. We should use forceps which are not toothed. It has to be carefully handled. Then we can also use certain sutures so that we can easily remove the tissue without tearing it. During the type of removal of the tissue, how exactly we are removing the tissue for the biopsy, sometimes we are also nowadays using electrocautery. Sorry. So this electrocautery can cause increase in the temperature around the tissue that can lead to damage of biopsy margins. Sometimes laser is also used. So if we are using such type of tissue or such type of method to remove the tissue for the biopsy purpose, try to keep the margins little away so that it does not affect the lesional tissue. If you go for the proper or the best method for the removal of biopsy tissue, I'll suggest that you should go for scalpel, especially number 15 scalpel. That is the best method to remove the tissue for the biopsy purpose. Okay, the tissue is being taken, then it is being sent to the oral pathologist. At that time, proper orientation of the tissue is not done. At that time, the oral pathologist feels it very difficult. Where exactly is the anterior margin? Where exactly is the medial surface? Where is the posterior surface? For that, the clinician should do proper margin. They should mark it properly. Either they can use silk suture and make a diagram on the sheet stating that which is the anterior, which is the posterior, or even they can use certain ink so that a proper site and proper surface of the tissue can be used. It will help the proper pathologist to determine the extent of the lesion, where exactly he has to look forward for the lesions. Okay, once the tissue is being taken, it has been properly collected. Now it has to be sent directly to the pathologist. This is the most important error which is seen during the biopsy procedure. Clinicians, most of them does not have formalin with them. So before taking biopsy procedure, it's a request to all the clinicians who are doing biopsy, they can ask from the pathologist to provide them with 10% neutral buffered formalin so that just immediately after taking the biopsy, they can put particular tissue into the formalin itself. That is the gold standard material or the liquid for saving the tissue for a longer period of time. The volume of the fixative which is to be used is also very important. There has to be like around 10 to 20 times of volume of the tissue has to be used. So sufficient amount of formalin fixative has to be used for preserving the tissue which has been taken for the biopsy. The jar we are taking, it also should be properly opened so that the tissue can directly be poured into it without damaging the outer structure of the tissue. On the jar, it has to be given a proper information. A proper label has to be given regarding the name, site, doctor's name, date, and everything has full information should be given on the box, and it has to be sent then to the transported to the pathologist. Never use saline, water, or dry gauze for the storage of the tissue. It has to be directly put it into the fixative so that it will prevent the architecture, normal architecture of the tissue. Okay, if the fixative is not properly placed, if the concentration of formalin is not proper, this will lead to a lot of fixation errors, and that will lead to damage of the tissue. It will cause autolysis, that is the self breakdown of the tissue. The cellular structure will shrink, the staining will not come proper, and again finally it will lead to difficulty in diagnosing the lesion. So it's better always, once you have removed the tissue from the oral cavity, directly it has to go into the fixative jar. Now, the responsibility of the clinician is to send proper clinical information to the pathologist so that it can also help in coming to a proper diagnosis. First of all, they have to give the name, age, gender of the lesion, gender of the person, the duration, the site from where the biopsy is being taken, what was the size, what was the extent, what were the different habits patient is having, does it have any medical history, diabetes or hypertension. Certain clinical photographs should also be sent. If there is certain bone biopsy or something like that, or relevant radiograph should also be sent. So all this complete information also has to be sent. If some of the information is missing, it can again lead to certain errors in diagnosis. Little bit about the container, because this is the most important jar which is transporting the tissue from the surgeon to the pathologist. It has to be a properly sized open container which contains sufficient amount of formalin, with the picture put on outside that is showing the name, age, and all the details regarding the tissue which has been taken. It has to be clearly labeled. It should be large enough so that the tissue which we are putting inside that should not be folded, it should not be compressed. It has to have patient name. There has to be certain identification number which is unique for particular that biopsy. It has to be have the date on which the biopsy has been taken, and also preferably that this container should also contain the name of the surgeon or the clinician who has performed the biopsy, and then after properly sealing the tissue, properly controlling that particular jar, it has to be transported safely to the pathologist as soon as possible. Certain special situations are there, like for example, in case of vesicobulous disorders, biopsy is not done from the lesional site. It has to be done from the perilesional normal tissue, not from the ulcer or not from the vesicobulous area. Or sometimes if we are not going for histopathology, or if we are going for some certain special stains like immunofluorescence, it has to be transported not in formalin. There are certain different transporting medium like Michel's transporting medium for the immunofluorescence technique. Sometimes it has reached the pathologist, everything is being done. Sometimes the pathologist suggests the biopsy has to be repeated. In this case, what happens exactly is, after giving the diagnosis is not coming proper according to the clinical situation. There is reappearance of the lesion, persistent lesion is there. The lesion is progressing. The tissue specimen was less. The clinical suspicion of the tissue appears to be malignant, but the biopsy is showing negative results. At that time, it is always advisable. It is always there has to be a contact between pathologist and surgeon, and they have to decide whether a new or re-biopsy has to be done. See, this is, there has to be a communication between the surgeon and pathologist, because it will prevent so many errors. If they discuss the tissue, they discuss the site, how exactly the surgeon could see the fluid coming out, how exactly he could see the walls of the lesion. If they are being told to the pathologist, then the clinical suspicion what exactly is having, all this will lead to lot of problems which can be saved in the proper diagnosis. Even the surgeon can also tell us how exactly was the margin of the lesion, what are the different follow-up findings he is observing in the patient. So all these communication has to be there between a pathologist and a surgeon for the proper diagnosis of particular lesion. Certain diagnostic pitfalls which can occur, like first of all was a sampling error, how exactly the sample is being taken. Then during the handling of the tissue, a proper force has been not, it has not gently been controlled. There are crushing artifact on the tissue which will be seen onto the microscope on the slide. Then it has been taken from the wrong side. A proper fixation has not been done. Incomplete history was taken, which has not been sent to the pathologist. Then there was not proper labeling of the tissue. The tissue has not been named properly. It has not given a proper number. Again, which will lead to a lot of communication error. That will lead to a lot of problems in the pathology lab. This will all lead to diagnosis problems. And sometimes what happens is the surgeons take the biopsy and they forget it to send it to us. So it has to be properly placed in formally. Then they should try to send it as early as possible so that a fixation, properly fixation, and the further procedure for the preparation of the slide can be taken off. So how we can reduce exactly different errors when we are sorry. So as a pathologist, it's a duty to reduce the amount of errors during the diagnosis, because so much of treatment aspect of the surgeon depends upon the pathologist's report. So what are the different checklists? What are things which we can check? Correct patient information has to be taken. It has to be from the correct lesional site, a most representative side of the lesion. A proper depth of the tissue has to be taken. Proper, after taking of the tissue, it has to be properly fixed. It has to be marked properly. A proper history form. There are certain forms which are being avoided, or they are being provided from the pathologist. Like I'm also doing this oral pathology practice in Agra. I'm also providing certain forms to general dentists, and I'm also providing them the formalin so that they can properly fill the form, and along with the tissue, they can send it to me. That will help us in helping. This will help us in coming to the proper diagnosis. So the key message, which is important for today's discussion, is if you see, biopsy is just not the removal of the tissue from the oral cavity and looking it under microscope and knowing the extent of the lesion. Representative sampling is most important, whether we are getting the proper sample of the tissue or not. Then it has to be properly handled from the clinician before sending it to the pathologist, so that the diagnostic quality which we are maintaining, it has to be properly handled. Then it has to be a close communication. There has to be a close discussion between the clinician and the pathologist that will also improve the accuracy of the diagnosis. And sometimes a re-biopsy should also be considered if the clinical findings, if he's suspecting, is something else, and pathology, the slide is telling us something else. In this case, before coming to the final conclusion, a re-biopsy has to be considered. So the last message, the commonest reason for a wrong biopsy diagnosis is not the microscope, it is choosing the wrong tissue. So from my side, you have to remember 5 R's. That is, a right patient has to be there with the right lesion. Then go for the right site of the lesion. Then follow the right technique for taking the biopsy. And then right specimen handling, so that it can be properly transported to the pathologist and a microscopic slide can be prepared for the diagnosis. So I'll end my presentation with all the things. Thank you very much for giving me this opportunity. The forum is open for question and answers. Thank you.
Thank you so much, sir, for this wonderful and comprehensive talk. The presentation you shared was very informative as well as easy to follow. So, may I stop your screen sharing for the time being, sir?
Yes, ma'am.
Thank you, sir. So, yeah, sir, we have received a few questions from our participating doctors. So, we'll be moving ahead for a question and answer round. The first question is from Dr. Joel Varghese, who is a dental intern in Kochi, Kerala. The question is, how can clinicians determine the most appropriate biopsy site to maximize diagnostic accuracy?
See, this is a very good question. Actually, the most common diagnostic errors occur from this particular area only. Actually, there can be a lesion which is looking hyperkeratotic. So we don't have to take it from the whitish area. We always has to take a incision or excisional biopsy depending upon whether it is an ulceroproliferative lesion. We have to take from the most suspected area. Most suspected area we have to take along with the lesional tissue and also along with the normal tissue. So from the clinical experience, it comes, we have to always compare whether this is looking a normal tissue or there has to be a little lesion. So from particular lesional site, the most suspicious looking area has to be taken for biopsy. Thank you.
Thank you, sir, for answering this question with such clarity. Moving ahead with the next question, we have received from the area of Bhopal, Madhya Pradesh, by a junior dentist. The question is, what are the most common technical errors during oral biopsy and how can they be avoided?
See, my full topic was related to the most of the diagnostic errors only. So there are so many errors, and most common errors which are occurring are not choosing the specific area for taking the biopsy, not taking the representative site. Okay, once you have taken from the normal representative site, then the next most problem error which can occur is the not taking the proper depth and the length of the tissue. Okay, which you have taken. Again, the error can occur. You are not proper gentle handling the tissue. You are crushing the tissue. Okay, you have handled it properly. Next, you are not properly transporting the tissue with the help of proper fixative. You are not using the proper concentration of the fixative. You are not taking particular amount of fixative to dip in that tissue into that box. Then you have to label it properly. If it is not labeled properly, again it can lead to error. It has to be transported properly. So all these areas which are occurring before the tissue is being reached to the pathologist, these all things are occurring at the level of clinician only. Basically, it is like selecting the patient, then taking the proper site, taking proper depth, proper fixative not using, proper handling of the tissue, and proper transportation of the tissue. Fine. Thank you.
Thank you for explaining that question so well, sir. So now we move ahead with the next question, which is from Guwahati, Assam, by a general dentist. The question is, how do specimen handling, fixation, and clinical documentation influence the quality of histopathological diagnosis?
See, the question is very, very important. How we handle the tissue is most important part our clinician has to follow. See, if he is not gently handling the tissue, if he is using the forces with lot of tools in that, that will lead to crush of the tissue. And that crush of the tissue will lead to distortion in the structural orientation, the nuclear damage, and all this will be finally coming to the microscopic slide, which again will lead to the difficulty in diagnosis. If we are not documenting, if you are not giving the clinical information regarding the patient, the site, because as we know, the site, oral site, it's all the different part of the oral cavity are having different type of tissues. Different types of, like tongue is having different type of tissue, or buccal mucosa is having different. So if the patient is having certain medical history, if the proper fixation has not been done, a tissue has not been properly fixed. So before reaching the pathologist, it will get damaged. It will get autolysis. Autolysis of the tissue will occur. That will be of no use for the pathologist. So all these stages, like proper handling of the tissue with the help of either sutures or gently handling, then using a proper fixative and proper documentation or proper photographs, which can sometimes help in diagnosis. All these should be given for the proper diagnosis of the lesion. Thank you.
Thank you for the wonderful explanation to that question, sir. The next question is from a final year BDS student from Chennai, Tamil Nadu. The question is, how should clinicians manage cases when histopathological findings do not correlate with the clinical presentation?
Yes. There are certain times when the clinician is suspecting it to be a malignant lesion, and the biopsy, the report has been come as uh, non-malignancy. In that case, there has to be a communication between the pathologist and the clinician. A clinician definitely should call the pathologist and tell that I'm suspecting it to be a malignancy. And then the pathologist will see the slide again. At that time, that comes the area or the time when the rebiopsy is always advisable. Always such type of communication error is there or such type of suspicion is there. Always advisable that patient should be given final diagnosis after one more biopsy has been done, along with all the information and along all the clinical aspects has been shared to the pathologist, and again the slide has been made. Then only a proper final diagnosis should be reached. Thank you.
Thank you very much, sir, for answering all these inquiries of the participating doctors so well and in so much detail, and also for generously contributing your valuable time and for sharing valuable insights with us on our platform. It was a pleasure having you with us, sir.
Thank you very much, ma'am, for having me. Thank you very much.
Thank you, sir. And I thank all the delegates, and I hope you found this session to be extremely valuable. So, with this, we conclude the session here for today. Hope you all have a great time ahead. Thank you once again, sir.